Hello, I am Dr. Sami Ulutaş from Bahçeşehir University Medical Faculty, Department of Neurology. Thank you, MedicReS, for this opportunity. I will speak about artificial intelligence in headache diagnosis. Did you know that headache disorders impact nearly half of the global population? Despite the common rate of these disorders, it's alarming to realize they are frequently underdiagnosed and undertreated. For instance, the diagnosis rate for chronic migraines is surprisingly only 25%. Patients often require multiple consultations to receive correct diagnosis, signifying a substantial challenge in healthcare. Only one of these disorders, migraine, have a significant burden, with the estimated economic cost reaching up 100 billion per year for a single country alone. The World Health Organization recognized migraine headaches as the second most disabling of all diseases and the leading cause in women under 50 years. This underlines the urgency of addressing the widespread health issue. To begin, it's important to understand how headache disorders are classified according to the International Headache Society. The International Classification of Headache Disorders breaks three conditions down to three main groups: primary headaches, secondary headaches, which are attributed to a secondary condition, and neuralgias and other types of facial pain. Our primary focus is on primary headaches, which include well-known types like migraine and tension-tip headaches, and some severe types like cluster headaches. Diagnosing this disorder often depends heavily on what patients report their symptoms, with anamnesis, which can take a long time and make the progress subjective and challenging, especially considering the limited number of doctors relative to the global population. This is precisely where we believe AI can play a crucial role. Artificial neural networks, also known as neural networks, are computational models inspired by the way of the human brain works. These networks aim to mimic the brain's learning function by stimulating the intricate information signaling biological neurons. As artificial neural networks, the fundamental components are nodes, and which often referred as artificial neurons, and the edges that connect with these nodes. These edges represent the flow of the information between two neurons. Imagine these artificial neurons as a tiny decision-making units, and the connections between them as the pathways for sharing the knowledge. As data flows through these networks, ANNs process information, recognize patterns, and make predictions. Just like our brains, neurons communicate to help us to understand the world around us. And just as our brains communicate, help us perceive and interpret our world, ANNs process data, recognize patterns, and make predictions, thereby for aiding in the accurate diagnosis of headache disorders we will use. However, the efficacy of these AI models are heavily dependent on the quality of and wideness of the data they are trained on. Real-world data is the lifeblood of the AI in healthcare, but it's not only enables these models learn and make accurate diagnosis, but also ensures their applicability in diverse real-world scenarios. These data helps us uncovering some new patterns, testing and evaluating models, and most importantly, ensuring these models are free from biases and are truly representative of the global population. So we know that the data is so important, and we will discuss now the crucial aspects of planning and organizing the data collection process effectively. Starting our data collection journey, we face a key choice. Should we go for a multi-center study or a single-center study? Multi-center studies give us more data from different centers. So, but they can be complex to manage. On the other hand, single-center studies are easier to control, but might not give us much data variety. So they are not generalized. Getting the data entry, the second one, the getting the data entry, collected data is so important, but often overlooked. We need to be really careful and follow the clear rules, and make sure the people entering the data are well trained. We make a brief training to our researchers for diagnosis and data entering process. Also, surveys are a big part of the collecting data too. We collect the data from surveys, via surveys. They need to be short, clear, and maybe standard, so everyone can understand and enter the data easily. As we say, data is the heartbeat of the artificial intelligence. In the realm of the big data, the qualification of the data is so important. For example, the hospital records. They are a goldmine for AI in healthcare. However, the quality and structure of the data are critical for accurate analysis and prediction. We offer prospective data collection, which makes proactive approach to gathering high quality of data. Maybe in the future, somewhere, the whole world will use standard forms. As our project, we prospectively gathered data over 8 weeks from 69 neurologists across 13 countries, ensuring a truly diverse population. This data encompassed demographics, headache characteristics, focal neurological symptoms, which are critical for identifying secondary headaches, headache triggers, and ultimately their diagnosis based on international classification of headache disorders. Regarding to the AI methods, I'd like to extend my gratitude to our researchers from Boğaziçi University, Berke, Sena, and Professor Yılmaz for their invaluable work. The upcoming parts of our study were meticulously analyzed by them. In the data pre-processing phase, we focus on 2 main tasks to ensure our data is accurate and reliable. The first one is handling the missing data. Missing data is common, but handling is crucial for the reliability of our analysis. And the second one is eliminating the outliers. Outliers, or unusual data points, you can see here, can skew our results. There are 2 methods, but we use the modern one, the isolation forest method, to identify and remove these effectively. In the realm of diagnosing headache disorders, data augmentation isn't just beneficial, it is essential, especially considering certain types of headaches may be overrepresented in our dataset. Augmentation helps us address this imbalance. We use data augmentation to introduce diversity into our dataset. Why this is crucial? Because some headache types like tension-tip headaches and migraines might be more common in the collected data. But we want to diagnose the rarer form, so by generating new example with this slight variation, we ensure our model doesn't become biased towards these more frequent types, and we can recognize and rarer types effectively. So this process is particularly valuable in preventing overfitting also. It helps our model generalize better and ensuring it performs well across all types of headache disorders, not just the ones in the most common ones in the training data. In overcoming the intricate and nonlinear relationship, our researchers choose to utilize fully connected neural networks. This approach allows us to delve into the complexities of the data without making any prior assumptions. After thorough training of our model, we integrated droplet layers at a rate of 10%. This strategic move is crucial for preventing overfitting. And the decision trees as a method used widely in statistics, machine learning, and data mining. The hierarchical structure of decision tree, this is the root nodes, branches, and internal nodes, and at the least leaf nodes. It mirrors the step-by-step decision-making process doctors use in diagnosing patients. So we want to use this method and compare the AI one. This structure allows us not only predict outcomes, but also trace back the path of the decisions. So we can understand why this is diagnosed and why behind each diagnosis. This transparency is particularly beneficial compared to the black box nature of fully connected neural networks, where despite their power and accuracy, the specific reasoning behind the given output remains obscured. So, in the other ones, in conclusion, decision trees offer a level of interpretability and insight into the diagnostic process. This is inherently similar to a doctor's method, allowing us to pinpoint the exact factors leading to a diagnosis. This is the graphical abstract where we presented in the European Headache Congress 2023. We used AI to help diagnose different types of headaches. We look two ways of AI can learn. One of is like a flow chart. This one is decision tree, and the other is like a brain. This one is artificial neural networks. We got information from 69 neurologists and prospectively used AI methods to make sure that our data was good and fair. Then we test our models and see how well, train and test, how well they could identify headache types. Here is what we found. The ANN method got the headache type right, 82%, and the decision tree method made a little bit better. It was right, diagnosed rightly, accuracy binary 85%. Both methods are pretty good at making sure they identified the headache types correctly. In conclusion, our study shows that AI can really help figuring out what kind of headache someone has. And the decision tree method was a bit better than ANN in our tests. We also noticed that it's harder for the AI since some headache types are very rare, even if we used augmentation compared to others, and we need more data for these types of headaches. These are the results. For accuracy binary, it was really good. For accuracy all, it means more than one headache diagnosis, a little bit lower because of lower rates of the other types of headaches. And in the world, what is in the world about this area? In the world of computer-based diagnostic tools, even though there are many, it is important to note that only 5 of research have been recognized for having both training and test data sets. So this distinction is crucial, as having both sets is fundamental for validating the tool's effectiveness and ensuring that it can accurately generalize beyond the data it was trained on. So, about the research, Yin et al. First, they use two classes. They make case-based reasonings, and they have high variables. They have high accuracy, really high accuracy, you can see, but their sample size are beyond 1,000. Walters and Smithermans, they use two classes. They use logistic regression. They didn't validate the test, so it is reasoning some questions. And they don't have not multiple classifier. And Van de Vel et al., they have three classes: migraine, tension-tip headaches, and trigeminal autonomic cephalagias. They have a really high validation accuracy, the 98%, but they have a very small validation. So it is also have some questions, raising questions about performance. And Kwon et al., they have 5 classes. You can see many classes, but high performance, even if they have high performance for migraine, the other types of performance were low. And the Katsuki et al., they use a really high number, 4,000, and deliver high diagnostic accuracy across for 5 class of systems, 5 class of types of headaches. But for the limitation, they have a really high accuracy also for migraine and for all headaches. For the limitation, they are single center study, and it is raising questions for generalizability. For the future, what can we say? We think that smartphone apps like Migraine Buddy are offering a detailed tracking and forecasting. While these tools integrated with some AI models, it would make a revolution for self-diagnosis and treatment access for primary headaches. But it's crucial to remember that secondary headaches still require a doctor's expertise. So we think that these models and some standardized tests can streamline primary level diagnosis, aiding family physicians and the other doctors in delivering a prompt and accurate diagnosis and treatment. Thank you so much for this opportunity.